Good evening, everyone. I want to welcome you all to Queen's Free Speaking of Health lecture series. My name is Lisa Sakia. I'm with the Corporate Communications Department here at the Queen's Health Systems, and I want to thank you all for joining us this evening. First, our topic for this evening is When Joints Disappoint, Getting a Grip on Osteoarthritis. And I'd like to introduce our speaker this evening, Dr. Scott Kawamoto. He is a rheumatologist, and he's actually an active staff member at the Queen's Medical Center. He received his bachelor's at the University of Hawaii at Manoa. He went to medical school at the John A. Burns School of Medicine. He did his internship and residency in the Internal Medicine Department at the University of Hawaii Internal Medicine Residency Program. He then completed his subspecialty fellowship training in rheumatology and immunology at Stanford University. He opened his private practice in 2009 and is a board-certified doctor in adult rheumatology. Please join me in welcoming Dr. Scott Kawamoto.
Well, thanks everyone for being here. I know it's dinner time, so try not to go too long, but till 7 o'clock so you guys get the free parking. Okay, so my disclaimer is here on the bottom. You know, this health information is presented for informational purposes, and it's not intended to replace discussions with your doctors. All decisions regarding patient care should be made with your doctor, who is able to consider the unique characteristics of each individual patient. So this is what we'll talk about today. We'll talk about how common osteoarthritis is, what causes it. We'll talk about some of the symptoms, how it's diagnosed, and we'll talk about some of the treatment options that are available. Just a couple of slides on what rheumatology is. Not everybody knows. There are about a dozen or so adult rheumatologists in the state. And rheumatology is a subspecialty of internal medicine. We focus on the treatment and evaluation of diseases that affect the joints, muscles, bones, and other connective tissues. As Lisa said, we do a residency in internal medicine after medical school, and then 2 to 3 years of fellowship training. So we treat a lot of different things, including osteoarthritis here, but mainly focusing on different types of arthritides as well as connective tissue diseases. So this slide looks at the prevalence of different types of arthritis in the United States, and you know, I think the thing that stands out about it is how common osteoarthritis is relative to other types of arthritis. And so it's estimated to affect about 30 million Americans, so about 1 in 10 US adults. And it's much more common than all of the other forms of arthritis put together. So in this green graph here, this represents over 100 different types of arthritis, and then gout, rheumatoid arthritis, and the arthritis related to lupus. So people come into my office and they're often concerned about rheumatoid arthritis, but osteoarthritis is much, much more common. So there are many names that we use to characterize osteoarthritis. We refer to it as OA, stands for osteoarthritis, wear and tear type of arthritis. Some people call it an old age kind of arthritis because it's more common as people get older, but it can affect all ages across the spectrum, including children. We often refer to it as a degenerative arthritis or degenerative joint disease. And kind of an older term is hypertrophic arthritis. And it's called hypertrophic arthritis because there tends to be a lot of bone formation in OA. So what causes osteoarthritis? You know, I think before we talk about OA, it's good to understand what a normal joint is. And in this slide, this purple stuff here is cartilage. And cartilage is very, very slippery. It's about 100 times more slippery than the surface of an ice cube. And it lets the bones glide easily over each other. And for larger weight-bearing joints like the hips or the knees, it also provides a little bit of a cushion. So in this cross-section of the joint, you can see that the ends of the bones are lined by cartilage here. And then there's a thin rim of space that encloses a synovial fluid. So this is a very slippery, naturally occurring fluid that allows the bones to glide. What happens in osteoarthritis is the cartilage starts to break down. So it starts off as these very thin microfissures and cracks, and over time it can progress, and these gaps in the cartilage can then expand until the bone itself is reached. If not treated, there can be significant damage to the joint, and with the complete loss of cartilage, the bones kind of move upon each other, so like a bone-on-bone type of appearance. What happens over time is the body reacts in a protective mechanism to try to protect the joint. And so there's a lot of new bone formation. So in this cross-section, all of this here is representative of joint enlargement. Sometimes these little bone enlargements can break off and they can float around in the joint, and we call these loose bodies or joint bodies. And this can cause a lot of discomfort, especially if the loose body gets kind of locked in position. This is a slide, I'm not going to go through it in detail, but this is a slide that looks at different inflammatory markers in osteoarthritis. And we typically think of inflammation occurring in illnesses like rheumatoid arthritis, but in osteoarthritis, there's a lot of inflammation that occurs at the level of the joint. So not so much systemic inflammation through the immune system, but a lot of local inflammatory changes in the joint itself. One of the interesting things is that it's long been known that patients that are overweight or obese have a greater risk of osteoarthritis, and that kind of makes sense for large joints like the hip and the knee. You know, if a patient is overweight, there's just a greater amount of mechanical stress. But interestingly, recent studies have shown us that at the level of the joint, inflammation changes in patients that are overweight. So we think that the adipose tissue, the fatty tissue itself, results in the release of certain chemical mediators that can then accelerate cartilage loss. So we'll talk about some of the risk factors for osteoarthritis. There's a cartoon just saying, the woman is saying that my mother's been dropping things and just found out it's because of arthritis, and the dog is saying, please be hereditary. So there are non-modifiable risk factors for OA and modifiable risk factors. So the most common non-modifiable risk factor is age. So again, it's more common as patients get older. The peak age of incidence, when it usually starts, is in the 40s. 45 is typically the age that's cited. But it increases as patients get older. So through the age of 65 to 70, it's estimated that almost 1 in 4 to 1 in 5 patients will be affected by osteoarthritis. Gender certainly affects the incidence of OA as well. Across the spectrum of different joint involvement, the risk is pretty similar for males and females, but there's a subtype of osteoarthritis that affects the fingers that's much more common in women, especially around the time of menopause. And then ethnicity and genetic factors also play a large role, and this is yet to be elucidated, but researchers are currently studying different models and different populations of patients to try to identify targets for treatment. Modifiable risk factors are things that we can change. So the most common one is excess weight, and I touched a little bit about the fact that patients that are overweight, in addition to the mechanical stress, also have a change in the inflammation of the joint. Previous injury predisposes to osteoarthritis as well. There's a model looking at damage to the anterior cruciate ligament of the knee, the ACL, where patients that suffer that injury early in life almost universally will go on to develop osteoarthritis later. And so they're trying to identify targets for treatment to try to prevent patients that have ACL injuries from getting OA later. Physical activity is a very, very, very important risk factor. You would think kind of intuitively that for a degenerative type of arthritis, the more you exercise, the worse that it will be. But in fact, research has shown the opposite. Patients that are physically active have a lower incidence of arthritis, and it can actually help to change the cartilage health itself. And then joint alignment, especially for the weight-bearing joints like the knees and hips, play a role. So commonly in the office, we'll see patients that are kind of bow-legged or knock-kneed, and it just kind of alters the way that the joint bears weight over time. And then, very importantly, you know, the other types of arthritis will also result in osteoarthritis. So rheumatoid arthritis, for example, will cause a secondary form of OA. The arthritis that's related to lupus can cause a secondary form of OA. And so we'll touch a little bit about the workup for this in the next couple of slides. But when we evaluate patients for osteoarthritis, we're always evaluating for other types of arthropathies that can coexist with OA. So symptoms vary very greatly from patient to patient. Again, they usually begin after the age of 40, and they often progress over time. You know, patients often ask me that if they're diagnosed with OA early in life, in their 30s or 40s, does that mean that they're going to ultimately require joint replacement surgery later in life? And the fact is that osteoarthritis is not a linearly progressive disease, so it doesn't always progress at the same rate in different patients. And again, in many cases, things like exercise can help to stave off progression of osteoarthritis. Now, the most common symptom, of course, is joint pain, and this joint pain is typically worsened by use and improved by rest. So this is in contrast to other forms of inflammatory arthropathies like rheumatoid arthritis, where the opposite is true. Usually patients with rheumatoid arthritis feel better when they're moving around, and they feel worse when they're at rest. The pain that occurs in OA typically is better in the morning, and it's worse throughout the day with activity. And it's usually episodic, so it tends to come and go throughout the day. It can come and go, for weeks at a time, and then there will be other times when patients have no symptoms at all. Many patients will describe joint stiffness or difficulty getting going. So when patients first wake up in the morning, they describe that it takes them a few minutes to kind of get moving or get loose. And the same is true after prolonged sitting. So sitting at the desk at work, or maybe sitting in traffic, or watching a movie, patients have to kind of guard themselves and kind of move a little bit more easily when they first get going. Now, typically the stiffness that occurs in illnesses like rheumatoid arthritis are much more prolonged. So patients with rheumatoid arthritis will similarly describe this difficulty getting going in the morning, but that stiffness can last for an hour or longer in some cases. Joint cracking, creaking, or locking is also very common. And again, if you think back to that schematic that showed the loss of cartilage, when you lose that slippery protective cartilage, the bones then kind of grind against each other. And so when you touch the surface of the joint as it moves, you can often feel grating sensation. And then joint swelling and enlargement of the joints is also very common. And again, this relates to the amount of local inflammation that occurs at the joint. So which joints are affected in OA? Basically, any joint in the skeleton can be affected, but there are some that are more common in primary forms of osteoarthritis. So the fingers and the thumbs are very, very commonly affected. The hips, the knees, and then the big toe, the base of the big toe is a very commonly involved joint. The spine tends to be involved, usually the cervical spine, so the neck, and the lumbosacral spine, so the lower back. The mid portion of the spine typically is not as affected in OA itself, but again, all of the other joints can be involved in OA, especially when it's secondary to other forms of arthritis. So when I see a patient in the clinic that comes in with osteoarthritis of the elbow, we look very closely to make sure that there's no other type of arthritis that may be contributing. So we'll go through a couple of pictures showing different osteoarthritis patterns. And this is a picture showing patient's hands, obviously. And so the thing that kind of sticks out is this joint enlargement over the knuckles. So usually these PIP, or the middle joints, and then the DIP, the distal joints, are affected in osteoarthritis of the fingers. And you can see that it can lead to this kind of enlargement of the bone, and in some cases, asymmetry or angulation of the joint. And so this occurs because bone formation, again, which is the body's protective mechanism against loss of cartilage, occurs asymmetrically. So the bone grows more quickly on one side of the joint than the other, and it causes the joint to get a little bit crooked. The other thing that's important to point out this picture is that the MCP joints, the big joints of the knuckle here in the hand, are typically spared in osteoarthritis unless there's some other form of arthritis that's contributing. This is another picture showing osteoarthritis of the hands, and this patient actually has a form of osteoarthritis called inflammatory or erosive osteoarthritis. And typically patients with this inflammatory or erosive variant have a lot of inflammation of these joints here. And on X-ray, they can often show destructive changes of the joint. So these erosive changes, which typically herald other types of arthropathies like rheumatoid arthritis, can occur in OA as well. This inflammatory erosive variant of osteoarthritis typically occurs in females. It's much more common in women, about 6 to 8 times more common than in men. And it typically starts around perimenopause. So we think that there's a large hormonal component. We also see that this inflammatory osteoarthritis typically runs on the female side of families. So there seems to be a large genetic component as well. So I'll show you a couple of pictures of osteoarthritis of the hand, and this is a normal X-ray here and then an abnormal X-ray showing osteoarthritis. And if you take a closer zoomed in look, you can see that normally the joint should be nice and even. So the edges of the bones are nice and smooth. The spacing in between the joint, which again represents the cartilage and the fluid in the joint, is normally nice and black here. So there's a nice, discerned line here between the joints. But in this slide here, you can see that that joint space has been kind of narrowed down, again related to the loss of cartilage. And there's been a lot of change in the underlying bone itself. So these are actually cysts in the bone, so-called subchondral cysts. And then there's a lot of bone formation occurring here. This whitish change here represents inflammation in the bone, again from the loss of cartilage. This is a diagram showing osteoarthritis of the thumb, and patients frequently present to my office complaining of pain in the wrist. And you can see that in this diagram here, it's very closely related to the wrist joint, but really relates to osteoarthritis at the base of the thumb. And on this x-ray, normally again, the spacing in between the joints should be, in between the bones should be nice and smooth here, but at the base of the thumb, you can see that there's very little space here, and there's actually some change in the bone. So this red arrow here kind of represents the end stage of osteoarthritis of the CMC joint, and it normally results in a kind of a squared off appearance. When you look at your hand, the base of the thumb tends to kind of almost take on a squared appearance. Osteoarthritis of the feet is very common as well, and this is a picture showing a hallux valgus deformity or bunion deformity. So you can see that there's a lot of new bone formation here, kind of allowing the joint to look very, very deformed. And then the toe kind of angulates out a little bit. So this is kind of a very severe case, and you might imagine that this patient will have difficulty wearing closed-toe shoes. These pictures demonstrate so-called hammer toe deformities. So over time, the loss of cartilage results in these permanent cock-up type angulation deformities. And these patients will often have a lot of discomfort when they're bearing weight as well. So one of the things that can be useful for these types of deformities is a so-called metatarsal bar. It's just an insert that goes underneath, in the shoe, underneath the foot, right kind of at the base of the toes. And it helps to kind of straighten out the toes a little bit. In many cases, these deformities are fixed, so you can't kind of straighten them out and force them and straighten them out. And so often we have patients wear larger kind of wide box shoes to accommodate for these types of deformities. This is an x-ray showing osteoarthritis of the knee. And again, this is a normal looking joint where the edges of the bones are nice and smooth and the space between the joint is nice and even and homogeneous. And this is a patient with advanced osteoarthritis of the knee. Again, the spacing is lost here, and you can see that the bones almost are kind of abutting each other. So this is a bone-on-bone type of appearance. There's a lot of change within the bone itself with these cystic changes, and a lot of this white sclerosis or inflammatory changes in the joint as well. This is a different view of the knee. So this is the kneecap here. So this is what we call a sunrise view, where the x-ray is shooting with the knee slightly bent. And it's kind of looking at the alignment of the kneecap as it meets the bottom portion of the thigh bone. And this is what a normal joint should look like. Again, the edges of the bones are nice and smooth, and the spacing between the kneecap and the thigh bone is nice and even. And in these diagrams, you can see that some patients with so-called patellofemoral arthritis or kneecap arthritis, the kneecap kind of slides off to the side. And over time, these patients will frequently describe difficulty going up from a squatting position or getting up from a seated position. And they often have difficulty going up and down stairs. And the reason that happens is because when the knee is bent at its maximal flexion, the kneecap tends to rub the most on the bone at that point. So there are different patterns where the kneecap can slide off to the inner portion or the outer portion of the joint, but ultimately can result in very severe arthritic change as well. This is a diagram showing arthroscopy of the knee. So arthroscopy is a surgical procedure where an orthopedic surgeon inserts very thin cameras into little pukas in the surface of the skin. And in this picture, there's a kind of mild osteoarthritic change. So there's a little bit of fraying of the normal cartilage here. But in this picture, you can see that all of this stuff here is not normal. So this is all fraying or tearing of the cartilage. And this leads to exposure of the bone, causes a lot of pain and a lot of inflammation. These are x-rays looking at osteoarthritis of the hip. So again, the normal hip here, where the spacing between the ball and the socket of the hip joint is nice and even. And in this patient here, there's very severe loss of that joint space. There's a lot of this white sclerosis or inflammatory reaction and some cystic changes as well that results from the inflammation. This can actually result in changes to the ball and the ball and socket type of joint. So you can see that compared with this side, the normal side is pretty nice and round. This side tends to kind of flatten out. So this is a patient with fairly severe osteoarthritis of the hip. And then again, osteoarthritis occurs in the spine, and this is a side view of the lower back, the lumbar spine. And normally, the vertebral bodies, the bones in the spine, are nice and even. The spacing in between the vertebral bodies, where the intervertebral discs or the cushions of the spine lie, are nice and uniform throughout. But in this patient with advanced osteoarthritis, you can see that there's been a lot of change in the bone itself and very severe narrowing of that intervertebral space. These patients can also have a lot of nerve root entrapment. So nerves come out of these little pukas on the side of the spine here, and when the nerve gets pinched on, it can cause very severe shooting pain, or in some cases numbness or even weakness of the muscles. So this patient with pretty advanced arthritis would probably be having a lot of those symptoms. So how do we diagnose osteoarthritis? The most important part of diagnosis is a thorough history and physical examination. Osteoarthritis can be diagnosed clinically just by an interview with the doctor and examination of your joints. We often use blood tests to rule out associated types of arthropathy. So again, we use blood tests to rule out things like rheumatoid arthritis and lupus, for example. X-rays are very commonly used to kind of get a stage of severity of the osteoarthritic joint, and also to help us rule out other types of conditions that could cause joint pain. So rarely we might see things like tumors present as osteoarthritis, and we rely very heavily on the imaging to help us distinguish between those two presentations. MRI scans are frequently used. MRI scans are a much more expensive study than an X-ray. So where an X-ray will be under $100 usually, MRI scan will be closer to about $2,000. But the MRI will show us a lot more information, and it will also show us whether or not there's damage to the soft tissue structure, so the ligaments and the menisci, for example, whereas X-rays will only show us bone. So MRIs are very useful if your doctor suspects that you may have had an injury or a tear to certain parts of the joint, but not necessary to diagnose osteoarthritis. And then lastly, we sometimes will use analysis of joint fluid via a needle inserted into the center of the joint to help us rule out other types of arthropathies, including things like gout. So in patients with gout, there will be very characteristic changes in the synovial fluid. In patients with infectious arthritis or so-called septic arthritis, there will also be very characteristic inflammatory changes in that analysis. So we're moving pretty quickly. So goals of treatment, currently there's no known cure for osteoarthritis. So the goals are really focused on the relief of pain. We also try to improve a patient's function and daily activities. And then, of course, the tertiary goal is to slow the progression of disease. And patients will often ask me, which treatment is right for me. And we'll get to this in a few slides, but it's very difficult. Every patient's a little bit different. Not everyone with an osteoarthritic joint needs to take treatment, especially if the symptoms are mild and tolerable. So who treats osteoarthritis? So your primary care doctor may be the one treating you. Again, rheumatologists kind of specialize in the treatment of osteoarthritis. Orthopedic surgeons are our colleagues that operate on the joint, so they do arthroscopies or joint replacements. Physiatry is kind of a newer specialty. So physiatry, not psychiatry, but physiatry, has to do with physical medicine and rehabilitation. So these are typically, historically, these doctors have cared for patients, for example, after they've had a joint replacement and they've been in the hospital doing a lot of physical therapy. And they also treat patients, for example, that may have had a stroke. But now in the outpatient setting, they're treating a lot of non-orthopedic joint pain as well. And they can also prescribe different medicines and do things like injections that help. Podiatrists are foot and ankle surgeons, so they specialize in treatment of the foot. Pain specialists will usually prescribe stronger types of pain medications to treat osteoarthritis. And then we work very closely with physical and occupational therapists as well. So these are some of the different treatment options that are available, and we'll touch a little bit on all of these. So this is a cartoon, and the doctor is telling the patient here that the handle on your recliner doesn't qualify as an exercise machine. And, we kind of joke about it a lot. Patients come in to see me in the office and, they have a painful joint, and then I tell them that, okay, you need to go out and exercise. It can be a tough pill to swallow sometimes, but exercise by and far has been shown to be the most effective non-drug therapy for reducing pain and improving function in a patient. It's the one thing that's been shown to prevent progression of osteoarthritis in comparison with all of the other medicines that are available. And again, while it may seem counterintuitive that patients with a wear and tear or degenerative type of arthritis should exercise, research shows us that patients can and should exercise regularly. So the way that I kind of describe this to my patients is you think about the model of cartilage loss in a joint. As a joint itself gets weaker, it's very important for the structures that support that joint to get stronger, to kind of strengthen the muscles around the joints and help increase flexibility and stamina. Weight control is also very, very important. So for patients that are overweight, it's estimated that for every pound a patient is overweight, it places an additional 4 pounds across the weight-bearing joints like the knees or the hips or the spine. And this is very, very significant. So if a patient loses 10 pounds, it decreases the stress across a knee joint or hip joint by 40 pounds. And some studies have suggested that the amount of relief of pain that they get from losing 10 pounds is similar to taking an over-the-counter medicine on a regular basis. And then, of course, exercise has the additional benefit of helping us to stave off other health problems, including cardiovascular disease and osteoporosis. So, I want to touch a little bit on osteoporosis. People frequently get osteoarthritis and osteoporosis confused, and they sound alike, but they're very, very different illnesses. Osteoporosis and its related illness called osteopenia have to do with the thickness or the density of the bone. So osteoporosis results in a weakened bone density and a propensity for the bone to break, so fractures in the bones, whereas osteoarthritis has to do with the loss of cartilage and has to do more with the articular structure itself. So what do we advise patients to do for exercise? There's no one exercise that's right for everyone. We usually advise patients to start with just common sense types of flexibility exercises, so just gentle stretching of the joint. Really makes a big difference, especially when patients have that sensation of stiffness after inactivity or when they wake up in the morning. And simple stretching for 10 or 15 minutes can really help to relieve that symptom and help to relieve pain. And patients that stretch on a regular basis typically have less pain throughout the day, even if you only do it in the morning or you do it at the end of the day after work, for example. From there, we kind of branch out to different types of exercises as appropriate to each patient. Strength training, weight training, resistance band training is very helpful to help strengthen the muscles. Aerobic exercise is very good. People often ask about, the utility of running. You would think that the jarring action of running would accelerate cartilage loss, but studies have shown that patients can run safely. Neuromuscular exercise has to do with things like balance training. So some patients, especially some of our older patients, will have difficulty with kind of their balance. They may feel a little bit unsteady, especially going up and down stairs. And so neuromuscular exercises help patients to protect themselves against falls. And then recently we've been using a lot of water exercise as well. Water is a really great tool to help patients move the joints. We usually refer patients to physical therapists that will teach patients an exercise program in the pool. And the pool serves a couple of functions. Number one, usually the pool is heated, so the heated water kind of tends to loosen things up a little bit. And then being in water is obviously somewhat of a weightless type of environment. So for patients that have a lot of problems bearing weight and doing land-based physical therapy, being in the water helps to take some of that stress off across a weight-bearing joint. Now, for patients that have difficulty with exercising on their own, we frequently will refer them to physical and occupational therapists. So physical therapists, these are all doctorates. So these are doctors that focus on treating larger joints in the spine. Physical therapists will usually help you strengthen your muscles and improve your flexibility and joint mobility. And they often use modalities such as heat or ice, ultrasound, water therapy again, and then things like TENS units or electrical stimulation to help treat these symptoms. And physical therapists often can help train you in the use of assistive devices. So we'll touch a little bit about this in a couple of slides, but assistive devices are things like canes or walkers, and these canes and walkers are now all over the place. You walk into like Long's and they have like a basket full of them, and you'd be surprised about how many patients use a cane or a walker incorrectly. So sometimes for patients, especially that are prone to falling, working with a physical therapist for a couple of sessions, an hour at a time, can be very useful to make sure that they're using it correctly. Occupational therapists are also doctors. They usually focus on treating the smaller joints. So we refer to OTs for example, hand osteoarthritis, arthritis in the fingers. They can make suggestions to help you manage your daily activities. So activities of daily living include things like dressing or eating or using the toilet or taking a bath. And occupational therapists can suggest often ways to do that in a manner that's safe for each individual patient. They often use modalities such as heat or ice or paraffin wax. So the heat of the paraffin wax tends to loosen up the discomfort in the fingers. And they will often fit our patients for custom braces and splints. So in the picture that I showed you of the finger that's kind of crooked, wearing a splint, especially early when the deformity is first starting to occur, can help to prevent progressive angulation, progressive loss of range of motion of the joint. So we'll talk a little bit about some of the medications. So acetaminophen or Tylenol is typically the first line medical therapy for osteoarthritis. This is medicine that works by relieving pain. It's very well tolerated. Not too many patients have side effects from it, and it's available over the counter, and it's very inexpensive, especially in the generic form. The drawback with Tylenol is that it doesn't work for everyone. It's estimated to help about 50% of patients. Usually the patients that present to my clinic are patients that have already tried these types of treatments, so we typically see patients with more severe arthritis. But for those that Tylenol is effective, it's probably the safest medication treatment for osteoarthritis. Now, of course, we always try to balance the risks of the medications with the anticipated benefits, and side effects of Tylenol are rare but can include things like serious liver damage, especially in patients that have pre-existing liver disease or those who take more than the recommended maximum, which is usually 3,000 milligrams in a day. And then patients who drink a lot of alcohol or have a history of alcohol abuse are also at an increased risk for liver damage. So it's very important not to take too much Tylenol. That can result in very serious and very sudden onset of liver damage. But when taken appropriately, again, Tylenol is a very effective treatment for a lot of patients with OA. The second line treatments are usually non-steroidal anti-inflammatory drugs, or what we call NSAIDs. And these are things over the counter like Advil, Motrin, or Aleve, and over a dozen or so different prescription types of anti-inflammatories, which are similar in the way that they work, but may have different types of dosing strategies or relative strengths compared with the over-the-counter types. These medications work by blocking the production of chemicals that cause pain and inflammation. So they work a little bit differently from Tylenol, which again is a simple pain reliever. These work by reducing inflammation. They're typically more effective than acetaminophen. The dosing is usually more convenient. So Tylenol is usually taken every 6 to 8 hours, whereas many anti-inflammatory medications may be taken every 8 to 12 hours, or in some cases once a day. Patients will often ask me which medicine is the best. I want to be on the best medicine, I want to be on the strongest medicine, but I usually tell my patients that there's no single anti-inflammatory medicine that's better than all the rest. It's a very individualized type of treatment, and what may work for your neighbor or your brother or your sister may not work for you, and that's also true of the different side effects that can occur. So one of the anti-inflammatories that may cause stomach upset in your neighbor may not cause stomach upset in you. So a lot of times it requires a lot of trial and error to find which anti-inflammatory is the best one for each individual patient, but with so many options that are available, it's really an effective form of therapy. Side effects with anti-inflammatory medicines are potentially more serious than with Tylenol, which is one of the reasons that we tried Tylenol first. But they can occur allergic reactions, so especially for patients that are allergic to aspirin, we never prescribe them anti-inflammatory medicines. Stomach upset tends to be a very common side effect, but bleeding ulcers could be a very serious side effect. So even when taking the short term, patients that take anti-inflammatory medicines are at a greater risk of bleeding ulcers. And the scary thing about these bleeding ulcers is that they can present suddenly, and they can be, in some cases, life-threatening, especially if they ulcerate and perforate, and there's like a puka in your stomach or your intestine. When you look very closely at the label for Advil or Aleve or Motrin, you'll see that there's a black box warning, so a very potentially serious side effect that they can increase the risk for heart attack and stroke. And
This is something that is especially true for patients with other risk factors for heart disease, so those with high blood pressure or diabetes or high cholesterol. And this is one of the reasons that we usually advise patients to take it for the shortest period of time at the lowest possible dose. There are also different forms of liver or kidney problems that can occur in patients that take anti-inflammatory medicines, and then increased blood pressure, leg swelling, and then also bleeding tendencies. So anti-inflammatory medications usually need to be stopped about a week prior to any type of invasive surgical procedure. So, they're a very effective treatment, but there are a lot of possible side effects. And because of this, we try to weigh the risks and the benefits for each individual patient. Again, they're safest when they're used at the lowest effective dose for the shortest period of time. And many of our patients with OA do take these anti-inflammatories on a regular basis. They'll take them every day because, for example, without taking the medicine, they may not be able to get out of bed, or they may not be able to dress themselves, or they may not be able to do their job. And so many of our patients will take anti-inflammatories regularly, but we try our best to monitor for possible side effects of these medications. And that includes regular office visits, regular blood testing, regular physical examinations. When you look at the label for the over-the-counter anti-inflammatories, there's usually a disclaimer that says, don't use for more than 7 or 10 days. And this is one of the reasons why they want you to discuss the use with your doctor so that they can counsel you about what the long-term side effects are. So second-line pain relievers. So tramadol is a commonly used non-narcotic pain reliever. This is not an anti-inflammatory. It's a stronger type of pain reliever than Tylenol. And then there are many different types of narcotic pain relievers. So these are things like codeine, hydrocodone, oxycodone, and as many of you are aware, these types of medicines aren't for everyone. There are a lot of risks with long-term use of painkillers. The CDC has declared a national crisis on the use and overuse of certain types of pain relievers because of the risks of addiction. And these medicines will frequently cause stomach issues, nausea, constipation. They can impair a patient's alertness and cause drowsiness and dizziness. And again, tolerance and dependence are very important risk factors as well. So with these types of pain medications, when they're taken, especially the narcotic pain medications, when they're taken for a long period of time, your body kind of gets used to that medication, and you require higher and higher doses to achieve the same therapeutic benefit when it's taken over the course of several months or several years. And that's where it can get a little bit dangerous. If osteoarthritis is a long-term problem, and if you're taking a pain reliever for several decades, over those several decades, you'll require higher and higher doses, and the doses can then become very dangerous. High doses of pain medications can stop your breathing and can cause cardiac arrest. So these medications are again reserved for patients with very severe pain who can't take or tolerate other types of treatments. Recently, duloxetine has been used to treat osteoarthritis. Duloxetine is what's called a selective serotonin and norepinephrine reuptake inhibitor, or SNRI. And this is it's a form of antidepressant medication, actually, and it's a capsule that's taken daily. And it's approved by the Food and Drug Administration to treat chronic musculoskeletal pain, including the pain that occurs in osteoarthritis. And it's also used to treat these other conditions, so depression, anxiety, diabetic nerve pain, and fibromyalgia. It can cause stomach upset. Dry mouth is very common. Patients will sometimes describe excess sweating, which, in the summer like this year can be very problematic. And then some patients will describe things like sedation as well, so they'll get a little bit sleepy. Now, serious side effects that occur with duloxetine include depression and suicidal thoughts. And this may seem like a little bit of a kind of an off-target type of side effect that would occur in a patient that's taking it for osteoarthritis, but a lot of the reports of depression and suicidal thoughts have occurred in patients that were taking the medicine for depression. And because of that, we warn patients about it, especially if they have underlying mood disorders, but we typically don't see the new onset of depression in patients with OA treated with duloxetine. We also monitor for liver damage. We monitor for certain types of medication interactions. And then duloxetine can also increase the risk for bleeding complications and seizures. So this is a medicine also that's not right for everyone, but it can be used very effectively in patients that maybe are allergic to aspirin, who have pain on a regular basis, and thus are willing to accept the risks of taking a medication on every single day. There are a lot of topical medicines available, so when you go into the drugstore, you'll see a lot of different things that can be applied to the surface of the joint. There are broad categories for topical medicines. Counter-irritants are things like camphor, eucalyptus, menthol, so icy hot, Arthrocare are the more common brands. These kind of stimulate the endings of the nerves to distract the brain from perceiving joint pain. Capsaicin has been used for a long time. Capsaicin is derived from chili peppers, and it blocks a neurotransmitter called substance P, which sends pain messages to the brain. The drawback with this chili pepper derived medication is obviously you can't use it and then touch your face. So for patients that have kids or pets, for example, it may not be the best treatment option. And then salicylates are similar to anti-inflammatory types of medications, and they include things like aspirin and Bengay. There are a few topical NSAIDs as well. So these are similar to the oral versions of the medications, but they have less systemic absorption. So only about 5 to 15% of the medicine is absorbed into the bloodstream. And so because of that lower systemic absorption, there is a lower risk of systemic side effects. Now, the drawback with topical NSAIDs is their cost. They're usually more expensive than oral NSAIDs. And so many times insurance companies will have step requirements where you have to have tried an oral medication first. The other drawback with topical NSAIDs is that they often need to be applied quite frequently, so in many cases 3 to 4 times a day. And some of the formulations take a long time to dry, so they're not quite like alcohol hand sanitizer where they dry very quickly. Some of them may take half an hour to really dry. So you can't put it on your joint and then get dressed and then go to work because you'll get it all over your clothes. So these are for patients with kind of unique situations that may be able to benefit from the topical form. But in general, topical medications have lower risks of side effects than systemic medications. The over-the-counter medications, the most common side effects are skin irritation and odor. We advise our patients never to use it with heat, especially heating pads. And actually, I saw this the other day in my office that a patient had applied these strips of icy hot with lidocaine and then applied a heating pad at night and then got pretty serious burns over the surface of the joint. So, it's always there on the label, but we try to remind our patients not to apply heat when the topical medicine's been applied. Corticosteroid injections are very frequently done in our office, and these are kind of cortisone injections or steroid injections, and they're very commonly used for arthritis in different joints. They're used for many other conditions as well, many different musculoskeletal pain conditions. They often provide very short-term, immediate relief. So they usually work within 1 to 4 weeks. They don't last that long, so usually by about 3 months and often by 6 months, there's no benefit. So, the reason that I probably do them the most is when a patient with underlying arthritis is having a really bad flare-up and they're having a lot of discomfort. The other situation that I tend to do a lot is when patients are like traveling. So when patients travel, they frequently are doing a lot of walking. So a lot of patients will come into the office a week or two before the trip and then get a shot, and that helps to reduce pain and inflammation while they're traveling. We try not to do too many injections. There's some basic science research that suggests that too many steroid injections can accelerate cartilage loss. This is a very, very small acceleration of cartilage loss. It was like 0.004 millimeters. And so researchers aren't really sure whether or not that amount of cartilage loss really results in any clinically meaningful symptoms. And when I consult patients about it, usually their pain is bad enough that they're willing to take that very, very tiny risk of cartilage loss. But that being said, there's no hard and fast rule about how frequently we can do injections. Patients, I guess it's kind of propagated on the internet and things, they'll commonly say that, they can't do more than 3 injections in a year, or my doctor told me I can't get more than 4 injections in my life. And, there's no hard and fast rule for the treatment of OA. So every patient's unique. We try to balance the risks and benefits for each individual patient. In general, corticosteroid injections have a very low risk of systemic side effects. There is a risk anytime you introduce a needle into the body, and especially into a sterile environment like the joint, there's a risk of infection, but it's very low, as you can see, 0.002%. Some patients will perceive worsening pain after the shot. Again, that's very rare. We think that's probably due to either a side effect from the medicine or in some cases just the fluid pressure, the pressure of the fluid within the joint. Bleeding and bruising can occur, and injury to the surrounding tissue is more frequent if you have an infection. When you have an infection in the soft tissue, that can be pretty serious as well. There is a small amount of systemic absorption of steroid, and so for some patients that are very sensitive to steroids, for example, patients with diabetes, or maybe very severe osteoporosis, we try to avoid using too frequent corticosteroid injections. And then viscosupplement injections. So these are approved for the knees only. Viscosupplements are a gel-like fluid containing hyaluronic acid. So HA is a natural constituent of joint fluid, and this is a kind of a thick viscous gel that acts as a lubricant and cushion for the joint. And so it's kind of like an oil lube for your knees, basically. There are many different medications that are available. These are all by prescription only. And they're usually done as a series of three weekly injections. So patients will come into the office for 3 weeks in a row, and then we'll do these injections. And you know, the benefit of the viscosupplement injections for the knees is that they often last longer than the steroid. So they can last up to 6 months or longer for many patients. The drawback is that they're much more expensive than the steroid. So a vial of steroid for a knee injection is, you know, the insurance usually charges like about $5, but a viscosupplement course will often be several hundreds of dollars. The utility of viscosupplement injections is really that they don't have the same amount of systemic absorption of steroid, and so you don't have the risks of long-term or repeated steroid injections. The risk of side effects is pretty low, but local reactions do occur. So some patients, especially that some of the older medications like Synvisc that were derived from the comb of a rooster, for patients that were allergic to chicken or eggs, they could have an allergic reaction to the medication itself. But many of the newer medications don't have that same allergic risk. So bracing and assistive devices, these are devices that support, stabilize, protect, and immobilize painful joints. I usually advise my patients not to use splints or braces on a 24/7 basis because you kind of get dependent on the brace. So ultimately, when it's used over and over, it'll result in muscle atrophy. And if you think back to the slide on exercise, it's really important in an arthritic joint to strengthen the structures that are supporting the joint. So bracing can sometimes be counterproductive. But for short-term use, for example, when patients are traveling or maybe anticipating doing a lot of walking, you know, they can provide a lot of stability, especially for a joint that kind of buckles. Shoe wedges and inserts are often used for patients with kind of like that bow-legged deformity or that kind of knock-knee deformity. And then again, canes, walkers, and wheelchairs can be useful for patients, especially if they're at a higher risk for falling. So this picture here is a picture of something that's available. You know, you can buy it over the counter. People order it on the internet. And these are just little plastic splints that kind of fit over the finger joints. They're pretty inexpensive. You know, they come in a big bag of different sizes, and they're useful for patients that are worried about that kind of crookedness of the finger. And so again, and they kind of fit snugly, and over time, they can help to prevent progressive angulation or deformity of the joint. Just one slide about the proper use of a cane. So a cane should be held on the good side. So if your knee pain is in the left knee, you should hold the cane on the right side. And it should be usually held at a height that allows your elbow to flex to 30 degrees. So in this patient here, you can see that the elbow is kind of bent to a 30-degree angle here. This patient here, the cane's too long, and then this patient here, the cane's too short, so it's kind of stooped over. And most canes now are adjustable, but you know, it's kind of a good rule of thumb. Your elbow should be able to flex to about 30 degrees when you're holding the cane. For stairs, we advise our patients to use one step at a time. So just go up 1 foot and then bring your next foot up, 1 foot, next foot up. And when you're going upstairs, you want to start with your good leg. And then when you're going downstairs, you want to start with the bad leg. So kind of useful guidelines to use a cane properly. And then one brief slide about regenerative medicine. So this is kind of a new and evolving field in the treatment of osteoarthritis. These include things like platelet-rich plasma injections, or so-called PRP injections, or stem cell injections. They often involve kind of the harvesting of a patient's healthy tissue and then purification of that tissue. and then re-injection back into the joint. And the thought is that these stem cells can play a role in reducing inflammation of the joint. And the problem with these types of injections is that there's a wide variation in research methods, and there's not a lot of standardized data. There's a strong influence toward marketing, and part of that is because these types of procedures are typically not covered by insurance. So they are very useful for some soft tissue conditions where they've been demonstrated to be helpful. In osteoarthritis, however, it's kind of unknown what the long-term benefit is and whether or not the cost of doing these types of injections are basically worth it over time. So. And then lastly, we call upon our surgical colleagues to help when medication options are either failing or not tolerated. And there are different types of surgeries that are performed for osteoarthritis. The first involves arthroscopy, where they make little pukas in the skin and then insert cameras, and they use very careful instruments to kind of clean out or repair the damaged cartilage. Osteotomy involves surgery to reshape the bone to increase stability. And then the most commonly performed surgery is arthroplasty, or joint replacement surgery. Now, one of the questions that I'm asked in the office a lot is, if my pain is bad, how do I know when I'm going to need a joint replacement? If I have osteoarthritis diagnosed at age 50, does that mean I'm going to need a joint replacement by the time I'm 70 or what have you? So the thing with the timing of joint replacement surgery is that there's no one simple test that will determine which patient should undergo treatment. And we try to balance the severity of a patient's symptoms against the risks and benefits of surgery. A patient that has very severe osteoarthritis but minimal or no symptoms certainly doesn't need to have a joint replacement. On the flip side, a patient with very mild arthritis or moderate arthritis that has very severe symptoms that's limiting their day-to-day activities might benefit from joint replacement surgery. So it's clear from research studies that patients that have more severe symptoms usually tend to benefit more from joint replacement surgery, but we don't base the timing of surgery on the severity of an X-ray or the severity of an MRI. It's really dictated by a patient's symptoms. And so we try to exhaust, obviously, all of the non-surgical treatments before proceeding to joint replacement, just because joint replacement, once it's done, it's done. There's no undoing that, and there is a risk of anesthesia, et cetera. But for many patients, this can be really significant type of lifestyle change. When they have pain that's limiting their ability to walk, and then when they're done rehabbing from the surgery, they're able to walk with no pain. It can be really life-changing. So we'll talk a little bit about some of the different supplements that are available. So probably the most commonly used supplement, and the one that you see most commonly in the market and the drugstore, is glucosamine and chondroitin. And so these are things like Move Free, Triple Flex, Osteobiflex. There are a lot of different formulations of these supplements, and many have different added ingredients. There are pure generic forms of them that are available at Sam's Club and Costco. I see a lot of patients using that just because they tend to be less expensive. The problem with glucosamine and chondroitin is that scientific studies have been conflicting. And while these supplements may have a beneficial effect for reducing pain and improving function, a lot of the studies have employed poor research techniques. So usually in a clinical study, we want to enroll a large body of patients so that we can detect small differences. But many of the studies looking at glucosamine and chondroitin use very small bodies of patients. And so because of that, it's difficult to detect and tease out whether or not they truly help. But there are small studies that suggest that it can help patients with osteoarthritis, specifically osteoarthritis of the knee. Sometimes patients that I see in the office, once they're diagnosed with OA, they go out to the drugstore and then they buy glucosamine and chondroitin, and then they take it every day thinking that it will prevent worsening over time. But there's currently no evidence that shows that this is the case. So we don't advise patients to take it to try to prevent arthritis, the onset of arthritis. We don't have patients take it to prevent the progression or worsening of arthritis over time. Now, the benefit of the supplements is that they're generally safe and well tolerated. Some patients will describe stomach upset. Rarely they can cause elevated blood sugars or bleeding tendencies, especially if they're taken in doses higher than recommended. We used to advise patients to avoid if they're allergic to shellfish, but now there are forms that are derived from shellfish-free products. Now, this is the biggest trial of glucosamine and chondroitin to date. It's the Glucosamine Chondroitin Arthritis Intervention Trial, or GAIT, and this is performed by the NIH, the National Institutes of Health. And it looked at different types of interventions. So it looked at placebo, which is a sugar pill, glucosamine alone, chondroitin alone, or the combination of glucosamine and chondroitin. And the thing that kind of stands out about this graph is they're all pretty similar. And when they did a statistical analysis of this, they found that there was a slight trend toward improvement in the patients that took the combination of glucosamine and chondroitin. But that improvement was defined as a 20% decrease in pain at 6 months. So, you know, how do you characterize or how do you materialize a 20% decrease in pain? We're not sure. You know, that's going to be different for different people. And so usually what I'll advise our patients is that if they are interested in trying glucosamine and chondroitin, we have them use the doses that were studied in the NIH trial, have them take it for 3 to 6 months, and if they're feeling better, they continue it. And if they're not feeling better, we usually will have them switch to an alternative form of it, a different brand of it, or just stop it altogether. Again, we don't advise patients to take it to try to prevent worsening over time. And other complementary alternative medical treatments for OA, there's a lot of information on the internet about diet, but when studied scientifically, there has never been a diet that's been shown to prevent the progression or worsening of osteoarthritis, with the exception of a diet that helps an overweight patient lose weight. Vitamins, there's no benefit from so-called treatment doses or mega doses of vitamins. We advise patients to maintain the normal recommended daily allowance. There's no need to take super doses of vitamin C or super doses of magnesium or even super doses of like calcium and vitamin D. Again, calcium and vitamin D can be useful in illnesses like osteoporosis or osteopenia, where the bone density or thickness of bone and the propensity to fracture is affected, but they don't necessarily help osteoarthritis. And then there have been there's been a lot of recent interest in turmeric, which is derived from a root. There's been some older data looking at boswellia and cat's claw. These are supplements that are available widely. Similar to glucosamine, there's not a lot of scientific data to guide us. They may be of small benefit. We don't know what the long-term risks are. And again, with any nutritional supplement, we're not really able to guide patients in terms of the risk of short-term side effects either, because there are often proprietary types of ingredients, and we don't know exactly what percentage of the ingredients are added to these types of supplements. So there's always that one caveat: we can't predict safety with supplemental treatments. And then lastly, acupuncture. So acupuncture is difficult to study scientifically. There's a small amount of data that suggests that it's helpful for osteoarthritis of the knee, but the duration of improvement is widely variable. There is a very small risk of retained needle or internal organ injury. Actually, I see this kind of often in my practice for patients that have had acupuncture repeatedly over the years, and we do an x-ray of the joint that's causing them pain. We'll see often these very fine metallic lines on the x-ray representing retained needles. And it can be a little bit problematic because the needles, theoretically, can't have an MRI if you have this type of needle in your body. So if patients have to be evaluated in the emergency room and they're having signs of a stroke, for example, there needs to be a careful analysis of risk-benefit. Now, it's very rare, but it does happen, so we do counsel our patients about that. So which treatment is right for you? So treatment choices are individualized. There's no magic bullet for the treatment of OA. The best initial approach is usually a combination of the lifestyle and medical therapy. So again, I want to stress that exercise is very, very important in treating osteoarthritis. CAM therapies, which are widely available off the shelf, are often a useful adjunct to therapy. There's not a lot of scientific data behind them, but for some patients, they do derive benefit. And then surgery is usually reserved for those who do not respond to conservative treatments. So in conclusion, osteoarthritis is very common, again, estimated to affect about 1 in 10. Most common symptoms are joint pain, stiffness, grinding, locking, and catching, and they vary in severity from patient to patient. They can vary in severity over time as well. And currently there's no cure, but there are many different treatments which are available to help with pain control and to help improve daily function for our patients. So 7 o'clock, I think that's...
Okay, now if you have any questions, please raise your hand for Dr. Kawamoto. We'll come down.
I have a question. The doctors said that I have bone spurs in major joints. What is that from?
Yeah, so the question is, what are bone spurs from? So again, in an earlier slide, I showed that the body's normal reaction to the loss of cartilage is often change in the bone itself. And there can be a lot of new bone formation that occurs in OA. So these bone spurs represent that kind of bony enlargement. Yeah.
I'm wondering about your opinion about massage therapy, especially fascia, you know, and the connective tissues, and what's that all about?
So the question was, how effective is massage therapy, especially treatment of the fascia itself? Yeah, so that's a great question. Massage therapy is very, very useful. It's been shown to help relieve a lot of different arthritic conditions and different soft tissue regional syndromes. The problem is that it's not normally covered by insurance, and then the effects tend to be very, very short-lived. So most patients will derive benefit for, you know, like a day or two, and it's usually not the risk, I mean, the cost and the, you know, benefit need to be carefully weighed for each patient. So I usually don't advise my patients to do massage, which is more of a passive type of treatment, unless it's in conjunction with a more active type of treatment as well. So we find from clinical studies that physical therapy and more active types of exercises are generally more beneficial. This fascia treatment is, yeah, somewhat new. There's a person in the community that does a lot of fascial treatments, and I think that has to do with more like the flexibility and range of motion types of exercises. Definitely beneficial. Yeah.
Question in the front.
I have a question. You said OA in the foot, and there's something in the shoes that you can put in there. Is that prescribed, or is that something over the counter?
Yeah, so the question was, for osteoarthritis of the foot, there's something that you could put into your shoe. So there's a metatarsal bar, and it is available over the counter. It's hard to find at like Longs and Walgreens and stuff, but you can order them online. It's basically a strip of either metal or plastic that just kind of props up the base of the foot. The podiatrists that we work with will frequently fit patients for forms of this with custom orthotics. So it's very, very useful. The problem is that the bars don't fit perfectly to every type of shoe. So it requires in some cases a custom fabrication that patients can do on their own, but it's a pretty simple fix for those types of hammer toe deformities. Yeah.
Okay, we have a question here.
Yeah, I have it in my fingers real bad, and sometimes the knuckles and my fingers swell up real bad, like these blisters full of fluid. And what is that fluid from? Inflammation? Because sometimes I get very frustrated and I just take a needle and pop it and drain it because so I can bend my fingers.
Yeah.
Is that good or bad or whatever?
Yeah.
And also, have you ever heard about CBD or bioastin? Do they do any good?
Yeah.
So what am I doing with popping these blisters?
Yes. So the first question is, sometimes on the arthritis of the fingers, there can be little fluid-filled cysts that form, and that's very common. We call these synovial cysts, and they occur when an arthritic joint produces so much fluid that the joint fluid kind of herniates out of the joint, but still remains lined by the joint lining. And so it communicates with the joint space itself, and it usually is not harmful. Sometimes people don't like the appearance of them. They tend to kind of come and go over time. Sometimes they'll last for several weeks or maybe several months or a few years even. But they're similar to ganglion cysts in that by themselves they don't really cause a problem. Now, you can cause a problem if you try to rupture them and they get infected. Then that leads to significant, damage to the soft tissue, and it can lead to infection of the joint itself. So we usually don't advise our patients to try to drain them themselves. Back, in the olden days, they used to call them Bible cysts because they would kind of bang them with a book and try to rupture it that way. But yeah, we don't advise that either. So if they're not bothering you, we usually advise patients just to leave them alone. The second question was about CBD oil, and bioastin. Yeah, so bioastin is a local company. It's produced by a local company. It's a derivative of astaxanthin. There's also a competitor out there called xanthicin, which is a biosynthetic form. Bioastin is a naturally occurring form. And, they're touted to have many different types of anti-inflammatory effects. Some of the studies suggest that they can decrease inflammation at the level of the joint. Whether they reduce pain or improve function, we don't know. And we don't know what the long-term utility is either. So some formulations are expensive. They tend to be kind of costly, but for some patients they work, and for others they don't, unfortunately. So yeah, it's hard to say. Same with CBD oil. CBD oil is kind of new. We don't have a lot of data regarding long-term safety or efficacy. But a lot of patients have been trying it, and some with significant benefit, and others it doesn't work at all. So.
Of the many different kinds of treatment you discussed, what's typically covered by regular Medicare and what's not covered? I know you said that stem cell treatment is not covered. Are there any other kind of treatments that are not covered?
Yeah, most of the other, the question is what type of treatments are covered for a patient with Medicare insurance. Most of those treatments are covered. Again, some of them are over the counter, but most of the prescriptions are covered. The one exception would be, again, PRP or stem cell, these regenerative types of injections. Those usually are not covered by Medicare and most commercial insurances as well. Some insurance plans will require step therapy where you have to try a certain type of arthritis treatment before moving to others. But most of those treatments, if they are approved, they are covered. Yeah. That's a good question.
Okay, we have a question here.
Two questions. First question has to do with PRP and what the variation is among physicians who do the PRP. I've had several PRP treatments to my knee in Scottsdale, Arizona, and they were all very effective and beneficial. Then I had one done in La Jolla, and my knees swelled up so much I couldn't walk. I ended up having to go to ER. And what would cause such a difference when they both call them PRP injections?
Yeah, so the question has to do with PRP, or again, this injection of platelet-rich plasma. So the way that the PRP injection works is the doctor takes some of the blood, they spin it down, they aspirate the buffy layer, which contains this platelet-rich plasma, which is thought to have some anti-inflammatory benefit. And the question was, why would one treatment work and the other treatment not work? I mean, that's a difficult question. It really would kind of depend. That's one of the criticisms of PRP and stem cell injections, is that there's no universally agreed upon protocol. And so they will differ depending on the kit that's used and the brand of the harvest, for example. But in theory, PRP or stem cell usually doesn't cause a reaction just because it's your own cells, generally speaking. That's one of the benefits of it.
So possibly the adverse effect could be the amount of the PRP that was injected into?
That is possible, yeah. So different types of kits will involve the use of a larger volume of fluid, and sometimes that volume is more than your joint can normally accommodate, and so that can sometimes cause a local pressure sensation. That's certainly possible.
And then can I ask one more question? There was a question about the use of cannabis oil. What about cannabis cream?
Yeah.
Same?
Yeah, so it's a little bit of a difficult subject. So I'm an allopathic physician. The question was, what about medical cannabis and different types of treatment? So I'm an allopathic physician. I'm not licensed to prescribe medical marijuana. So I never recommend it in my practice. There's not a lot of long-term data, and there's no short-term data for the treatment of osteoarthritis with cannabis. That doesn't mean that it doesn't work. It's just not studied. It's going to be very difficult to study this moving forward, because it's still illegal on a federal level. And so it's unethical to enroll patients into a clinical study when the compound is illegal. But some patients will use it, and some patients derive benefit from it. But my practice, I never recommend it.
Okay, let's give a round of applause to Dr. Scott Kawamoto. Thank you so much. I also want to say mahalo to the folks at the Arthritis Foundation. You saw them outside. They had those wonderful information cards they were giving out. That's Miley Kawamura, Karen Clark, and Bree Arnold. I also want to thank our Queens volunteers, James, Liu, and Nicole Bui, who is helping us this evening. Let's give them a round of applause. Thanks, James. Thanks, Nicole. And I want to tell you about our next Speaking of Health lecture. It is going to be on diabetes. It is called Living with Diabetes, How to Take Control. More than 100 million U.S. adults are now living with diabetes or pre-diabetes. If you're one of them, how can you live a long and full life with diabetes? We have Dr. Lisa L. Wong, who is an endocrinologist at the Queens Medical Center. And if you come, she's going to answer the questions, how is diabetes diagnosed? What is the difference between type 1 and type 2 diabetes? What can you eat if you have diabetes? Good to prepare for Thanksgiving, yeah, and Christmas. Where can you find help and support? And also, what are some of the new treatment options out there? This is going to be Wednesday, November 14th, 2018, from 6 to 7 p.m. right here in the Queens Conference Center. If you want to make reservations, you can go to queens.org and click Classes and Events, or call our Queens referral line at 691-7117. And that's going to do it for us this evening. Thank you so much for coming. Don't forget to get your tickets validated outside with Erin, and good night.